Good morning. Welcome to our second session, The Clinical Challenge of Managing a Pandemic, featuring Professor Ashish Jha of the Harvard Chan School of Public Health and Harvard Medical School. Our moderator is HBS Professor Robert Huckman. Please note that a recording of this session will be made available to a broader public audience. If during the Q&A you're called on to pose a question, your name and voice will be part of that recording. Over to you, Rob.
Great, thank you, Willie. And I want to thank everyone for being online with us today, particularly the members of the RC class. We are thrilled to have you all here in this way and to continue the discussion that got off to a great start with Ken Chenault and Karen Mills just a little while ago. So I want to welcome today Professor Ashish Jha, who is the KT Lee Professor of International Health and Health Policy at the Harvard T.H. Chan School of Public Health. He's also the director of the Harvard Global Health Initiative, and he is also a practicing internist at the VA Boston Healthcare System. He received his MD and MPH degrees from Harvard. He was a chief resident at UCSF, and before completing his fellowship at Brigham and Women's here in Boston. Now, if you see Ashish's face, he may look familiar. In the last few weeks, he has been on pretty much every major news outlet I can think of, ranging from CNN, PBS, Fox News, and MSNBC. So in true bipartisan fashion, I think it's important to note that he has said during one of those interviews that the coronavirus is an insidious disease that does not respect state borders or national borders, and by the way, doesn't care if you're a Democrat or a Republican. Now, before I get started, I want to just mention one more thing about Ashish, which is that in late February of this year, he was named the next dean of the Brown University School of Public Health, effective September 1st. So he's got a ton on his plate right now. And despite the pain of our losing him as a member of the Harvard faculty, we know that Ashish's international focus and reputation will continue to benefit all of us, and frankly benefit the world for many years to come. And we'll all have a chance to continue to benefit from his wisdom and insight. Now for today, we actually get a chance to do that directly and locally just with our group of now 440 participants. And so with that, I'd like to welcome Ashish. Ashish, it's great to have you here.
Rob, thank you for both an excessively kind introduction and for inviting me. It's going to be a lot of fun. I'm looking forward to it.
I knew you'd tell me that. You're a very modest person, and I knew you'd say it's excessively kind, so I've done my first job well. So I want to just jump right in and note that Ashish, you've been certainly a repeated and very early observer of the fact the U.S. response to the coronavirus has been both too slow and started too late. Okay, can you tell us what you see as truly the major reason for that? Because it could be that it's political, it could be that it's because of something about us as Americans and how we respond when we see a crisis that is coming our way, or it could frankly be some other factor entirely having to do with availability of resources. Can you give us your sense of what the biggest issue is there?
Yeah, and Rob, thanks for both having me on and getting us started there. What's interesting is, so I think by every objective measure, and I'll get into what those objective measures are in a second, every objective measure, the American response has been slow. We've been playing catch up. What's interesting is we're not alone. And I think, and I don't know how to sort of articulate this very well, but when the history of this pandemic is written, and we look back to countries that responded well versus countries that did not, it's not just America. It's a lot of Western democracies, others too, by the way, that have really been caught flat-footed. In some ways, the American response is almost kind of singularly bad. But we are not alone in how badly we've done this. And that is interesting. And I don't think the problem is democracy, but I don't know what part of our governance structure really failed us. So let's talk specifically about why I say it's been slow. We knew this virus was spreading across China and had good reasons to believe it was going to land in the United States by somewhere between mid and late January. And we can argue, was it January 15th or was it January 30th? Doesn't matter. And we spent a good 4 to 6 weeks just doing nothing to prepare. So what are the things we needed to do? we needed to get a testing regime up and running. And the failures of the testing regime have been well documented. Happy to get into that if it's necessary. But we just could not figure out how to get a test up and running and widely deployable. Second, we had a very good sense by mid-January of the impact it was going to have on the healthcare system. We saw it in Wuhan, right? We saw healthcare systems there getting overwhelmed. We saw the building of the 1,000-bed hospital in 10 days. And we did not spend the last, from again, mid-January through mid-March, we should have been preparing. We should have been building ventilators. We should have been getting personal protective equipment. There's a whole set of things that we knew we would need, we should have been getting, and we didn't. And we really didn't communicate to the American people what was coming. And that may be in some ways the biggest failure of all, because a big part of leadership and crisis management is communicating to people, even with all the uncertainties people have, of what's coming down the pike. Actually, there's a great piece by Michaela Kersey, who's a professor at the business school, recent graduate, and Amy Edmondson, professor at the business school, just I think out yesterday or day before about
in HBR. Yeah.
In HBR, fabulous piece about leadership and what great leadership looks like and what the costs of bad leadership is. And I think everybody should read that. And we really did have this kind of catastrophic failure across all of these things. And we are in a national lockdown, I think in large part because of that. We continue to struggle with these very basic things. And the notion that a country with our size, creativity, resources has had to shut down because in some places we don't have enough swabs, in some places we can't do a test. It's really, it's surprising to me. And I have to tell you, I've been a little surprised at how flat-footed we were as a country.
You did raise a point, and then you said we can talk about it later. So I'm going to pick up on that, which is about the connection with democracy and response in this case. Do you feel that there's a fundamental disconnect or lack of flexibility that a democracy has in responding to this, or is it our particular democracy?
Yeah, it's a very good question, and because, and again, there are people around here, our Kan Fung, for instance, at the Kennedy School, who's real experts on democracies and how they function. I'm not one of them. And of course, being a big fan of democracy, I tend to want to defend it. And so I'll give you my defense where I don't think it's democracy per se. South Korea did a really good job on responding. They're a democracy. Germany has done a pretty good job of responding, better than us. They're a democracy. I do think, and of course, China did an abysmal job of responding initially, and they're not a democracy. So I don't think it's about democracy. It is clearly something about governance and ability to make decisions, trust in government. It's a set of other factors that, again, I think people much more expert than me are going to have to sort out. But it is remarkable how some countries did a pretty good job and others have just done an abysmal one.
Yeah. Well, I want to pick up on another piece from your initial comments, and certainly from the writings that you've done recently and the appearances you've done. You've been a huge advocate for increasing the level of testing in the United States. I think there have been many voices that have suggested we also need to do that. And you've continued to do that even as, say, our first set of hotspots in the US have started to perhaps hit their initial plateau. I won't call it a peak because it doesn't seem to be a peak, but a plateau. So thinking of New York and New Jersey and those areas. But I will note that even during that time, I don't know when you made this change, but you changed your Twitter name to Ashish, quote, "I'm still focused on testing, Jha." And I think I'm probably then asking this a bit rhetorically, but I have thick skin and I'm going to give it a go. But are we at a point where the virus has gotten so pervasive in the US that the value of testing for active infection is perhaps decreasing, while maybe the value of testing for immunity might be increasing? And should we be shifting our focus of testing at this point, or is there still a lot of value in the active virus testing?
A great question. And I will say, no shifting. So let me walk you through why. And I actually am a huge fan of the serology testing that's started appearing already. I think it will provide enormous amounts of value. But we shouldn't confuse or overestimate what the serology testing will do. So let me take like 2 minutes and talk through testing.
That'd be great.
So if you begin at the top, we have a virus and we have a completely susceptible population, meaning most Americans, it's a novel virus, have never encountered this virus before. So all of us are vulnerable to being infected from this virus. So the question, like in any basic epidemiologic model, what will happen is you introduce a new virus into a susceptible population, it will take off. And the speed at which it will take off is the R naught, how many people does the average person infect, and it will keep going and keep going and keep going and infecting more and more people until it starts encountering large numbers of people who've been previously infected, and then it'll start slowing down until it hits so many people have been infected that it hits herd immunity and the virus essentially peters out. That's how this stuff works. So there have been places and countries that have said, oh, let's just kind of go through that and have herd immunity. The problem with that approach, of course, is massive numbers of people die and health systems get crushed. So we think that's not a great strategy. So how do you prevent that? Well, you want a vaccine. That's what you want, but we don't have a vaccine. So if you don't have a vaccine, how do you prevent person A who's infected from giving it to person B who's not infected? There are two ways. Actually, there's one way. Make sure person A doesn't come in contact with person B. So if you don't know who's infected, you put in social distancing. Just shut the entire economy down. Everybody does everything by Zoom and virtually. And Rob, you and I are, I can't infect you and you can't infect me right now because we're talking to each other virtually and we're physically far from each other. So social distancing is the crude way of making sure person A doesn't infect person B. But social distancing has massive costs, right? We've shut the economy down. If you want to let the economy start functioning, people are going to start interacting with each other. In which case, person A will now come in contact with person B and infect them. How do we prevent that in a context where the world is open again? You got to identify that person A is infected and you got to pull them out so person B can go around and be safe. The only way you can identify the person A is infected is by testing for active infection. So there is no other way. It's social distancing or testing and isolation. I don't know a third path for stopping the spread of the virus. Okay, now a couple of things about that testing. Once the infection gets very out of control, testing and isolation alone won't work. It won't alone work, which is why we had to put in social distancing. If we had a fabulous testing infrastructure back in February, we could have probably avoided all of this, but we didn't. So you had to put in social distancing to kind of shut everything down and bring the infection rates way, way down. Once you do, and you open up the economy again, infection rates are going to start rising again. And that's when you implement a very vigorous testing and isolation strategy. If you put in a testing and isolation strategy while you're shut down, by the way, it does help the shutdown move faster and have more benefit. So even now it's useful, but the moment we decide we're going to end social distancing, we have to do it. Let's talk a little bit about serology testing. And serology comes in two flavors. There's one flavor that everybody talks about, which is IgG, which is essentially looking for immunity. Did you at some point in the past get infected? And if you did, do you have an immune response to it now? We know that there are probably a lot of people out there in the community who've been infected, but either didn't know it or couldn't get tested. So as of this morning, there are about 600,000 Americans who are known to have been infected with COVID. So if you ask me how many people have actually been infected, the answer is I don't know. We'll know more when we do serology testing. But if you said, what's your best guess? I would say easily 10 times that. So instead of 600,000, easily 6 million Americans. Well, that's pretty good. It means that maybe 2% of the population has been infected. Probably not enough that you can use that information to open the economy, right? You can't run the economy with 2% of the population. Then there are people who say it could be 100 times. Maybe there are 60 million Americans who've been infected. That would be fabulous. I'm skeptical that 100 times have been infected. Could I be wrong? I could absolutely be wrong. And if it turned out that, that 60 million Americans have already been infected and most of them have recovered, my goodness, that would be awesome. So we're going to all pray for that, but I'm not counting on that. My guess is 10 or 20 times as many, so 6 to 12 million, in which case we still have a long way to go. So serology, very helpful, but not for opening and running the economy. you need to be able to make sure person A who's infected is identified and separated so person B doesn't get the infection. It's that simple.
Yeah. Well, and we can come back, what we will, to sort of talking about this reopening question. I want to hit on one other piece, though, when you talk about the numbers infected.
Yeah.
Also thinking a bit about something we've heard a great deal about in the last week, which is about the disproportionate burden of this disease on certain populations. I think when we initially heard about the disease, we were told this is going to be something that's going to particularly hit the elderly hard and the medically compromised very hard. Yeah. What we've learned as this has played out in several of our larger urban areas is that it's also hitting African-American populations very hard, those with lower economic means very hard, and arguably many of our service workers too very hard. And so the question of this disproportionate effect, you're someone who's long studied disparities in healthcare, both at the domestic and international levels. How do you see the lessons maybe that we can learn from the burden of this disease across different populations, and any thoughts as to what might be driving that?
Yeah, it's a great question. And so let's talk about what we expected and knew, and then let's talk about what we didn't expect, or maybe we should have expected but hadn't sort of explicitly been discussing. On the issue of older people and immunocompromised or people with chronic disease, there are a couple of points I want to make. One is we saw that data coming out of China. We saw it coming out of Italy. It's coming out again in the US. There are two kind of things that maybe everybody doesn't know. One is what we've seen in the US and in Western European countries is that the number of young, healthy people who have gotten very, very sick and have died is actually much higher than we were expecting. They still are much smaller than older people or people with chronic disease in terms of proportion, but it is not a totally benign disease for young, healthy people. We don't totally understand why. There is a small proportion who had this incredibly vigorous immune response, and basically that immune response destroys their lungs and they die. And we don't have a good alternative, and immunomodulating drugs so far haven't had much of an impact, not that we've studied it all that effectively. But there is this group and we don't get it. So I think it's not totally benign for young, healthy people. Second is this issue of older or immunocompromised or chronic disease. It's a pretty large group. So for instance, people say, well, people who are over 65. Okay, well, that's a good chunk of Americans as it is. Then we also talk about people between 40 and 59 who have any kind of chronic disease. And then you start saying, what kind of chronic disease? And you say, well, people with hypertension or diabetes. Well, almost 40% of males between 40 and 59 have hypertension. That's a lot of people. And when you start adding it up, you start getting into numbers like maybe 100 to 120 million people are at risk. That's a third of the entire population and almost half of the adult population. So when you have somewhere between a third and half of the adult population who are high risk, that's a pretty sizable group that you want to try to, and so there's been this idea of, well, what if we just protect the high risk groups and let everybody else go out? It's hard to know how you run a country taking a third to half of adults out of the mix. So it's a very, very broad group. On the issue of minorities, specifically African Americans, where the data has really been very clear and consistent and disturbing, there are two sets of data that I think are worth people understanding. One is we've seen much higher rates of infection, and then given infection, we've seen much higher rates of mortality. So two separate set of phenomena. Obviously, I don't have the answers on what's going on. I have speculation. I'll just share them with you. One is, as you alluded to, Rob, a lot of African Americans, a lot of people who are poorer tend to work in industries where they can't call into work using Zoom, where they are on the front lines. And so meaning they're interacting with people and they're taking often mass transit if they live in big cities. And their ability to social distance is much, much more limited. Or they may have jobs, or they may have economic means where if they took a month off or 6 weeks off, it would be so financially devastating that they have to make a very, very difficult choice, increase their risk of getting infected or starve. And obviously people will choose to try to continue making some money to feed their families. So that's why I think we see higher rates of infection. But then the question is, given a rate of infection, why do we see so much higher mortality? And here, I think the chronic disease stuff we've been talking about, African Americans have higher rates of hypertension and diabetes. There is some data, I think, that air pollution and long-standing exposure to air pollution is a huge risk factor for bad outcomes from COVID. And we know that African Americans, on average, in cities, live in neighborhoods where air pollution is much, much worse. So I think that's actually a potentially important driver. And then last but not least, a lot of work we've done, other people have done, shows that the healthcare systems, the doctors, the hospitals, that disproportionate care for minority patients tend to have poor quality care, tend to struggle with a lot of issues. And so you can imagine that even at the end of all of everything else, if an African-American patient ends up in a hospital, they're more likely to end up in a poorer quality hospital. Put it all together, and there are probably a whole bunch of other factors I'm not even identifying. Put it all together, it's not a surprise this is where we are, but it is a huge disappointment, and I think it's something that we ought to address much more readily.
So I'm in a few minutes, we're going to turn to our first year students for some questions. And so I would encourage them to start thinking through those questions that you'd like to ask Ashish. And before doing that, I want to come back to this issue, Ashish, that you raised earlier that has been all over. It's obviously front of mind for so many of us, which is thinking about how do we balance the management of this crisis with the eventual need to reopen our economy and our society.
Yeah.
And my sense is, given the number of things that have been written by any number of observers, clinical or otherwise, there are a lot of blueprints out there. What would you see as some of the key aspects of your blueprint for how we should think about the reopening of either parts or all of our economy?
Yeah, that's a great question. So just this past weekend, I was speaking to several different governors about what they should be looking for and when to reopen. And what I try to say to them is that there is no magic date, there is no magic moment, and that it's a series of trade-offs, right? As all complex things are. And the longer you wait, the more time you spend getting ready for opening, the better the chances that you can stay open. So my line on this has been, you can open whenever you want. The question isn't can you open, it's can you stay open? And can you stay open? Because I believe, and I'm not an economist, but I believe that if you open and then 6 weeks or 8 weeks later have to shut down and have to shut down for 4 months, in many ways, that's much worse than an initial delay in opening. And if you can stay open, right? It's that uncertainty in the opening and closing that's actually got additional problems. So what are the metrics you want to look for to open? And then what does opening look like? And then how do you stay open? So what experts have been arguing is you want to see declining number of cases, of new cases for at least 14 days. Why 14 days? 14 days. It sort of gets you a one cycle, a couple of cycles of transmission, a sense that you're clear evidence that you're heading in the right direction, that social distancing is working. There are a lot of reasons why 14 days. What if you did it after 10 days? You could do it after 10 days, just you're sort of increasing your risks that you're going to get a flare up in a way that you won't be able to control. Second is you want to have ubiquitous testing, and as important as the number of tests is you want to have a really smart testing strategy. And that essentially is you want to identify people with mild symptoms or any kind of symptoms. You want to do substantial contact tracing so you can identify everybody who's been around them, and you want to be able to isolate all those people. And then you want to start gearing up your healthcare system, because when you reopen, cases will go up, right, by definition. And some people will end up getting sick. The health systems of a lot of cities and states are really battered right now with the large number of COVID patients. You want to give your system a little bit of a chance to recover. There are doctors and nurses working 100 hours a week. You want to give them a chance to rest up. You want to fill up your supplies of PPEs and stuff so that if and or when you get another surge, you can manage it a bit more effectively. Again, I didn't give you any hard numbers on any of those things. It's just the more that you can do, the better you are equipped to stay open. One last point on what reopening looks like. There are not going to be any baseball games this summer, certainly not ones where people will be going to Fenway Park. The idea of 35,000 people crowding into a park over the summer is a nightmare, because a few infected people can fuel a big infection and have the entire eastern Massachusetts shut down. So we're not going to be able to do things like that. But I can imagine restaurants and bars opening, maybe with some social distancing built in. I can imagine people getting together for coffee and people being able to get back to work, and maybe super crowded offices are going to have to put in some policies around distancing. So there's a lot we can do to make opening a reality. It won't be back to normal. We will not be back to normal until we have a vaccine, which I think is a good 12 to 18 months away.
Well, Ashish, you are, I noticed in your bio, the one thing you don't have is an MBA degree, but you have shown us today that you are extremely good at talking us through the costs and benefits of a series of very complex and challenging, both clinical and managerial decisions. And so now I want to unleash some of our resident experts to ask questions.
Right.
So I will turn to Willie to see if we have any questions from our first year students.
Thank you, Rob. If you're an RC with a question for Professor Jha, please click on the raise hand icon on the toolbar at the bottom of your screen. And because our time is limited, please no long preambles, just pose your question concisely. I'll start when I call you. I will unmute you, and then you will have to respond on that. Let's start with Suhal.
Hi, thank you. I just wanted to ask a question on this last point. In terms of easing social distancing and the scale of the testing that needs to happen for that. I mean, what kind of timelines could we be looking at in order to get this testing in place? And maybe more specifically, as you said, there's a bit of this difference of a gathering of 10 versus 100 people. So what do we have to believe in order to think that, say, come September, that having 90, 95 people in a classroom together would be possible?
Yeah, I'm largely ignoring, I've been asked by a whole bunch of university leaders about, are we gonna be able to do classes in the fall with 90 students together? And I'm largely punting because it's an honest, I don't know, but I can talk about what it might take. So right now we're doing about 130 to 150,000 tests a day. We've ballparked that as a country, we should be, if we could get to about 500,000 tests a day by the time we reopen. So with our disease numbers will have come down, we should have enough testing that we can more or less get through the summer. We can have, if somebody wakes up with a sore throat and a fever, they can get tested, their contacts can get tested, and there aren't going to be major delays. That we can do the things that we need to do to keep things open over the summer. I think that number of 500,000 is doable. It's not totally easy, but I think it's doable by, let's say, June 1st. A lot of governors, of course, are itching to go by May 15th. And if, it's not a yes or no. If we're at 400,000 by May 15th, that might be okay. But as soon as we can ramp up more, the better. The problem of September is once you start getting 90, 100 students, you really need, in order for that to be safe, the amount of infection in the community has to be really, really low. And the amount of immunity in the community has to be really, really high. And I don't know how much immunity there will be because I don't know how many people are infected right now or have been infected, right? So, but I'll know more, we'll all know more in the next 2 to 4 weeks because the serology testing is starting to really ramp up. So that will help us make better decisions. And it is entirely possible that if a reasonable number of people have been infected by then, and that we have fabulous testing by September, we could potentially, and number of infections in the community are low, we could run MBA classes with 90 students in the classroom. Maybe we'd have to think about splitting it into 2 groups of 45 and a bit more spacing between students. I can imagine those kinds of changes, but we should be able to have students on campus in the fall. But it depends on a bunch of things, including things we're going to learn relatively soon.
Our next question is from Camille Gregory. Go ahead, please.
Thank you for joining us. I'm curious about some of the longer term impacts on how our healthcare system works. Specifically, what do you think it would look like in terms of how we train medical professionals and things like scope of practice changes that we've seen waivers up right now, but what will that look like in the future?
Yeah, fabulous question. And obviously we're still very much in the early days of this pandemic and the effects of the pandemic on the health system. Well, let's just say this, the epidemic will be with us for at least another 12 plus months, right? Because so we're going to be in this kind of funny state and managing the disease outbreak, at least for a good another year or so. And we've made a bunch of policy changes to better equip us. CMS has made a bunch. I actually think CMS has been fabulous on this. They've just made a lot of very smart changes, some of which you alluded to around scope of practice, changing rules about telemedicine. My general feeling is we're not going back. I understand those were created for short-term flexibility. And I think we're going to discover is we can do, we knew this, right? And I think we're going to learn this, like we're going to have to show that in the data, that a lot of this scope of practice stuff that we've relaxed, we should have relaxed years ago, but this was the impetus to do it. A lot of the movement of a lot of care to more virtual stuff, we're not going to be like, okay, we're no longer going to pay for any of that and everybody has to go back to their doctor's office. Like, we will keep those. I think we'll also discover that some of the things that we thought were totally doable virtually may not be. And it's not going to be perfect. So there will be a new normal. I don't exactly know what that new normal looks like, of course, but I think it's going to shift much more towards these things. I also think that, and this is a bit beyond your question, but things that we used to struggle with, there was a lot of vilification of the pharmaceutical industry. And sometimes the pharma industry behaved very badly, and some of they deserve to be spanked for some of the things. I think they're going to come out as heroes in this, and we're going to feel very differently about innovation because we're going to discover very quickly how much we value new things in the context of a new threat. And then probably the thing that I think will be, for me, one of the big silver linings, assuming this all goes the way I think it will, is that this is really going to be a very serious death knell for the anti-vax movement, because it's going to be very hard to be anti-vaccine, and we're going to, I think the faith in vaccines as a mechanism for getting people out of these very serious conditions is going to be restored. So those are, I think, some of the positive things. In general, I think our health system emerges battered, but ready, and it's going to look different. And I think most of those differences are going to be positive ones.
Our next question is from Miriam Serban. Go ahead, please.
Can you hear me now?
Yes.
Okay, thank you so much for sharing your views. I also have a question about opening under certain conditions. Do you think we can also talk about opening internationally, and what will be the additional conditions that we need to consider? I'm mainly asking this thinking about international students that are trying to plan for summer and fall. Thank you.
Yeah. No, so it's a very good question about international travel and what will be. So there is a policy-driven, like a kind of a data evidence-driven, like how I think about it. And then, of course, there's the issue of this stuff gets deeply politicized, and what the Trump administration is going to do on international travel, I can't really predict. But I think that the number of active cases, kind of population burden in Western Europe, for instance, is not going to look very different from what it is in the United States. And there will be some hotspots and there will be some places, but I think in general, there will not be much of a justification for travel bans to Europe. Like, that doesn't make any sense that we need to do that. And of course, there's going to be pressure to open those up. Could I imagine that we'll open up the travel bans, but then still ask people to self-quarantine for 14 days and when they come back? Like, that could happen. So it could be that, if you are from France and you go home for the summer and you come back in the fall, that there will be a 14-day period where the government will ask that you self-quarantine. Of course, the alternative is we'll have a ubiquitous testing, and it might be that you come back and 3 days later you can get a test and you're negative and then you're good to go. So there'll be a bunch of different strategies that we can do. And there are people who are suggesting that maybe we make testing a prerequisite for travel. And so you have to get a test in the 24 hours before you get on an airplane. And if you want to fly into the United States, you have to get a test 24 hours before you get on an airplane to the United States. I can imagine those kinds of things could go in that could allow for more travel. There is going to be obviously a pressure to do more domestic and international travel. And I think people will have to think through, how do we do it in a way that's reasonably safe? I don't personally worry hugely that this will become a major source of new infections, but policymakers are going to worry a lot about that. And so they're going to have to be more assured.
Our next question is from Namia Mahajan. I'm sorry if I mispronounced that. Go ahead, please.
No worries. Hi. So I had a question on the lockdowns. So it's being said that the lockdowns will shift the peak, but perhaps not lower it or reduce total numbers by themselves. And I'm asking from the context of like other countries and their policy decisions as well. So I was just wondering what you thought about that.
Yeah, so lockdowns are temporizing measures, right? And they don't ultimately change. Imagine there was never a vaccine and we just sort of had to, eventually all the countries, whether you have a lockdown or not, will end up getting the same number of infections until you get to herd immunity. What lockdowns do is they, as you guys have seen, flatten the curve and spread things out more. And so by definition, in lockdown, some infections are coming later than they would have otherwise. That's actually the entire point of the lockdown. In the short run, they will lower, obviously, the number of people infected. 6 months or a year later, will you have meaningfully fewer numbers of people infected if you went through a lockdown? Probably not. So lockdowns are really to do two things. I think of lockdowns as one, to give your health system a shot at taking care of everybody who does get sick. And second, to buy yourself time so you can be open without having to shut down again very, very quickly. Those are the two main reasons for lockdowns. If you don't use your time in lockdowns for those two reasons, you're essentially wasting the lockdown. And so we're in a lockdown. India's in a lockdown. I've been on Indian television a lot, arguing you got to use this time to dramatically scale up your testing infrastructure, because once you open, the number of cases will start rising again.
Our next question is from Sam Yuma.
Thanks so much, Dr. Jha. I just had a quick question about just how this potentially changes the conversation on universal healthcare, particularly as is centered on the United States, given that, as you know, around 16 million or more people have lost their jobs, and much of us, our insurance is tied to our employer-based status. So I just loved your thoughts on whether or not this changes that moving forward, because you said we maybe not be going back to the system from before.
Yeah, it's a very good question, Sam. And this is one where I don't know if I have a ton of expertise on the kind of political calculus of how this plays, but let me say a few things from a policy point of view as I see it, both as a physician and a health policy researcher, expert. So I think it certainly helps make the case for universal coverage in a way that has been, people kind of believe it in general, like most Americans believe that everybody should have access to coverage. But like, I think this really amps that up in a way, because the idea that there are going to be people who are going to be uncovered during a pandemic, I think most Americans will find much more distressing than what they would have felt before. So getting to universal coverage, which is different than a single payer system, of course, I think has become much more compelling. Second, the issue you brought up about employer-sponsored insurance, and is that the right strategy? Part of the point of Obamacare, Affordable Care Act, was like all those 16.6 million people who filed for unemployment in the last 3 weeks, they should be able to go on the exchanges and get new health insurance. And it should be very, very substantially subsidized, if not essentially free, because those people by definition don't have a lot of money. It does still raise a lot of complexity in the system. And there may be more will now to say, we want a less complex system. And that pushes that helps the single payer advocates to say, why are we dealing with all this complexity? Let's just move. The one kind of counter argument to that is people really, really value the healthcare they have, even if they think it's annoying, even if they think it's, and so in a moment of uncertainty like this, the idea that you would have this big transition and you would end up giving up the insurance you have and go to a government-run single-payer system, I think will make a lot of people uneasy. And I'm not talking about the merits or not the merits of it. I'm just saying in terms of a politically. So I think it's tricky for me to know how this plays out. I suspect it's going to increase the forces for getting us to close to universal coverage. And I think we should obviously harness that. Whether it creates political momentum for a Medicare for all plan, I don't know, because I can see competing forces going in opposite directions.
Well, I want to thank everybody for the questions. Let me turn it back to Rob Huckman at this point.
Thanks Thanks, Willie, and thanks to all of the students for those great questions, and Ashish for elaborating on some of your earlier responses. I think you have made it one thing very clear to us, which is that there is either the likelihood or at least the high potential for some significant change that will come about as a result of this crisis. And one, before we let you go today, I was hoping we could get you to reflect a little bit on how emerging leaders and MBA students might play a role in this crisis. We have seen an unbelievable outpouring amongst our students. The MBA's Fight COVID-19 project is just one example. And our students are hungry to think about ways they can contribute, realizing that in the very, very immediate term, this is largely about comforting patients, saving patients, and doing whatever we can to support the frontline patients and caregivers. But are there ways you could see our emerging business leaders playing a key role as we start to think about this next set of questions that sit ahead of us?
Yeah. So Bob, let me use that opportunity, that question, to answer a slightly different question. I'm not a politician, but sometimes I play one on TV.
Yet again, a very good MBA student. Go ahead.
So one of the questions I want to answer, I just want to raise, because it keeps coming up and it annoys me to no end, is that we have had a debate in America which has supposedly pitted public health experts versus business people and economists. And I think it is possibly the dumbest debate we could be having. So let me kind of first lay out why it's a bad debate, and then I'm going to talk about leadership, especially from the business community, and then we can finish up with students. So one of the things I get all the time, and there are people who say, well, businesses want to open up again. And I say, I want to open up again. Like everybody wants to open. Who likes this? No one likes this, right? So the problem isn't, do we want to open up again and the public health people don't and the business people do? I get why business people want to. Like people have spent their entire lives building businesses that they have seen in the last 2 months come crashing down. And if they have to wait another 2 months, it might actually completely end a life's work. I am deeply sympathetic to that argument. The point that I like to raise with folks is imagine that we just open up. Let's say we say May 1st, we're opening. We'll still have a good number of cases that are active and new. We won't have a testing system that's in place. And what will happen is as follows. By June 1, things will look fine. By July 1, the number of cases will be spiking around the country. By mid-July, hospitals will start getting overwhelmed. Large numbers of people will start dying. Doctors and nurses will start getting sick. Tell me in that context, who will want to go to restaurants and bars and get on a plane and go to Disney World when like you're seeing large numbers of people, including members of your family, getting sick and dying? No one. And people will clamor for the economy to get shut down again. And we will shut down and we'll stay shut down for 4 months because that's what's going to happen. Maybe 3 months. But the point is, there is no trade-off here between the economy and public health. And by the way, if we stay shut down much longer, there are massive public health effects of all this economic depression. So we have to find a third path. And one of the things that's been interesting to me is, and I don't mean to be critical, but I don't know that I've seen business leaders. I see a lot of business leaders who feel like they're deer in headlights going, oh my God, I don't understand this. This is well outside my area of expertise, and I don't know what to do. All I know is that my business is getting destroyed. And what I would love is for the business community to be far more engaged. Everything I just told you, you don't have to be an infectious disease epidemiologist who can model different R-naughts with different susceptible populations. You just have to understand the basics of what I just described. And if you do, you understand that we can't open up unless we're ready. And if we open up, we have to have a bunch of things in place. And the business community should be an advocate for smart public health because it helps the business community stay open and move ahead. So I would love to see more of a marrying of these two communities because I think we have exactly the same goals, right? Which is we want to keep the economy open. We want to keep people from dying. And I think we can do both. And we're going to need a lot of expertise and ingenuity. I keep arguing for 500,000 tests. I'm not going to create those tests. And let's be honest, the government is not going to create those tests. They're going to come from the private sector. How are we going to implement 500,000 tests a day? That's supply chain and logistics. they're the business community, like they know how to do supply chain and logistics. There's just all this expertise that I want to see tapped in. And, you know, and for students in this, first of all, I think engaging on these projects, there are new companies that are starting to try to solve some of these problems. There are models that people are starting to build. And I think there's a lot of expertise that comes from the business community that we are not tapping. I can talk about infectious disease and disease outbreaks and diagnostic testing. I know very little or much less about what great leadership is in this context. I know very little about logistics and supply chain and execution, things that you guys are fabulous at. And if there was a way for greater engagement between public health and business, I think that's how we get out of this and that's how we succeed. If it becomes us versus you guys, we all lose. We have both horrible number of deaths and a wrecked economy. And there's no reason for us to land there. So this is very much a united we stand, divided we fall situation. And we ought to figure out how to do that better.
Ashish, I want to say just on behalf of all on this session today, how grateful we are for the time that you've spent with us. The balance in your views is very refreshing and so helpful to educating all of us about where this situation is and what we each can do to be engaged with getting us through it. So thank you so much for taking the time.
Thank you.
Thank you. And Willie, I'll pass it back to you.
Thank you, Ashish Jha and Rob Huckman.